Carol's written in about constipation. She's been troubled by being bloated and uncomfortable and not moving her bowels, and she only moves her bowels once a week, and this is a real issue for her. And indeed, it's a real issue for many Australians. Up to sort of 15% of Australians over the age of 65 will use a laxative on a regular basis to try and establish a bowel pattern. So when someone presents with constipation, as a clinician, we like to know how long they've had this problem for. Is it new, which could imply there's some structural issue with the bowel, something even quite serious, or is it a long-term issue, something that they've had for a long, long period of time over decades? It's still important for us to exclude potential structural issues of the bowel, like bowel cancer, for example, or diverticular disease, for example. But our approach, again, is nuanced based on how long the history goes for. So when we talk with Carol, we'd like to know what her diet is like, what amount of fibre are you having, Carol, what amount of fluid intake are you having? And let's hear a bit about your bowel habit. Has it just recently changed, or have you been like this for a long, long period of time? I think it's important to have this discussion with Carol about why people develop constipation. The bowel is just a long, hollow tube, and in some of us, it just doesn't function very well. The bowel doesn't contract and push and peristalse very well, and that patient may have what's called slow transit constipation, and we can measure that. We can measure that with a variety of investigations using a safe nuclear isotope. We can tell how long it takes for material to go from one side of the bowel to the other side of the bowel. So slow transit constipation is something we're thinking of, but more particularly perhaps in a lady too, we're thinking about issues that are developing around the pelvic part of the bowel. And there are lots of problems that develop in the pelvic part of the bowel. So some patients have issues where the bowel is not very well supported by the pelvic floor. And if Carol's had a family, particularly if there have been difficult obstetric events, then she may well have some weakening of the pelvic floor. Maybe she's had a hysterectomy. We'd like to know about any pelvic surgery. That also has an impact on the pelvic floor. And sometimes the bowel sort of collapses forward on itself when it's being asked to empty, and that's called a rectocele. Sometimes it telescopes on itself when it's being asked to empty. That's called an intussusception, and we have ways of determining these problems, and they create mechanical issues with the evacuation right down at the level of the pelvis. Occasionally, patients also have a problem that develops with the rectal sphincter mechanism, where they are contracting the sphincters when they should be relaxing them. And often patients don't realise they're doing this. This sort of paradox is called obstructed defecation or anismus. It's a bit more common in younger people, but it's certainly something we have to think about. And often those patients will say that they pass stool that's very sort of thin and ribbon-like. They may not always even sense that their bowel has to empty. So there are all sorts of different issues that we're thinking about. Is it a problem with general propulsion? Is it a problem with just the pelvis? Or is it a combination of both? Or is it that there isn't that much wrong with either the pelvic part of the bowel or the transit through the bowel, but just that their diet's not really very well structured? They're living a difficult, busy lifestyle. They don't have enough fibre in their diet. They don't have enough fluid in their diet. So we would take Carol and have a good talk with her about this, and we might want to evaluate her because of her age internally with a colonoscope, which is a thin telescope with a light source and a video chip on the end, which allows us to examine for structural problems. We might not do that in a younger person necessarily, but certainly someone of this age, we're very keen to be sure we're not missing some extra pathology. And if her symptoms have developed reasonably recently, that's a very important consideration for Carol. Then we're going to talk about the sorts of practical things. Let's say she's had a colonoscopy, it's all clear. There's no structural issue that we can see. We're not very good at telling about intussusceptions and about that problem, anismus, by colonoscopy. We've got different ways of assessing those. But let's just say we're going to give her some advice. We'll ask her to develop a habit. Try and go to the bathroom at a regular time. A bit Pavlovian. Keep your fluid intake up. Have a good balance of fibre. But if you have a lot of fibre and you're very bound up, this will ferment. So the paradox there is that we introduce fibre as the bowel starts to work. We might ask her to use a gentle laxative, and there are lots of different laxatives. There are some that bring more fluid into the bowel. They're called osmotic laxatives, and there are laxatives that are stimulatory. Often they have cascara, senna-based products in them, and they're all fine, certainly in short-term use. If we were going to evaluate her from the pelvic sort of perspective, looking at the pelvic concerns for constipation, we might range to have a type of study called anotectal manometry, which allows us to look at the sphincter mechanism and how robust it is, whether it's contracting appropriately or not. And there might be x-rays that we do to look for rectoceles and intussusception. There's a whole range of things that we have to do. It gets quite complicated, but it also helps us tease out for Carol the exact underlying mechanisms that have led to her constipation.